تمام.
So go on. Yes.
بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله وبركاته. Good evening, everyone, and welcome to Iraqi Stroke Network educational webinar series. All these webinars are endorsed by Middle East and North Africa Stroke Organization. This is our 21st educational webinar. Today's sessions focuses on highly practical topic, how imaging determines treatment eligibility in acute stroke care. My name is Dr. Alsultani, neurologist at Karbala Al-Hindiya Teaching Hospital. I'll moderating this session in collaboration with my colleague, Dr. Zahra, who will lead to the question and answer session. Dr. Zahra, could you please briefly introduce yourself and explain how the question and answer will be conducted?
Good evening, everyone. My name is Zahra Hamid, the neurologist at the Dmaghiya Teaching Hospital. I will be leading question and answers sessions at the end of Lecture 1 lectures. Please feel free to post your question in the chat box during the talk. I will read them aloud during the question and answers. And if you would like to ask question verbally, you can use the raise hand function. And thank you.
Thank you, Dr. Zahra. Before I introduce our main speaker, we will start with a short scientific introduction to the topic to frame today's discussion and align our clinical thinking. This introduction will be delivered by our panelist, Dr. Dilan. Dr. Dilan is a consultant interventional radiologist based in Slemania, Iraq, with experience in acute stroke imaging and endovascular decision making. Dr. Dilan, please. Go ahead.
Good afternoon, everyone. It's actually an extreme pleasure for me to welcome you all to today's session, and thank you very much, Dr. Mustafa, for inviting me to your session today. The pleasure is mostly coming from the fact that the topic of this is how imaging determines treatment eligibility in acute ischemic stroke. I'm a consultant interventional neuroradiologist, and clearly, as you can imagine, my clinical practice sits in the intersection of imaging, decision-making, endovascular treatment. In acute stroke, few specialties experience as directly as we do as neurointerventionists how we realize how imaging findings translate most of the time within minutes into treatment decision. As we all know, over the past decade since the positive trials in 2015, acute stroke management has undergone profound transformation. We can call it a paradigm shift. We have moved predominantly over the past 10 years or so from time-based model of care when it comes to acute ischemic stroke to a model of care that's tissue-based or imaging-based. So imaging is no longer what we call it simply answering the question or confirming or excluding a hemorrhage or an ischemic stroke. It has become a primary tool through which we determine who is eligible for intravenous thrombolysis, who can proceed to mechanical thrombectomy, and equally importantly, if not more important, who will not benefit from this based on risk-benefit analysis. So what we call it in the hyperacute setting, imaging must answer several critical questions when we talk about imaging. These questions must be answered both rapidly and reliably. So first of all, we all know this is hemorrhagic or ischemic, and then whether they're large vessel occlusion or not, they're amenable for endovascular therapy or not, whether we have established infarction and how much is the established infarction compared to the salvageable brain. And these affect the following. They affect imaging, patient selection for treatment. They affect workflow activation. So we need to activate the workflow, like we need to activate NGO, we need to activate the stroke team and all this. And ultimately the functional outcome of the patient, which we say we will mention it as in MRS in 90 days. So the introduction of CT perfusion, CT angiography, and all this advanced MR techniques are the one that help us decide for the reperfusion of these patients. Like, it's not only, as I said, we have stroke or not, we have hemorrhage or not. It's that the perfusion, sorry, that the imaging that tell us which one to proceed to the right treatment. And clearly these ones has introduced few new challenges. When you have new imaging tools, they have new challenges. We have clinical judgment, we have decision bias, we have interpretation bias, and we have the fact that softwares included in this, shall we rely on them? How much we rely on them? Artificial intelligence will be included in this. And these are all time, clearly. We need to decide based on all these variables we have, how much we rely on this. So I feel I'm extremely lucky to be a panelist today, and I encourage an open discussion we all benefit from, because I always say to my colleagues, if there's one thing that link all of us, emergency physician, neurologist, radiologist or neuroradiologist, and neurointerventionist, we have a common thing in between us, apart from clearly the patient, is imaging. So I'm extremely happy that we are lucky to be involved in this, and I will leave it back to you, Ali. Hopefully our esteemed speaker will shed some light on this important topic. Thank you very much.
Thank you very much, Dr. Dilan, for setting the stage so clearly. And now it is truly an honor to introduce our distinguished guest speaker, Associate Prof. Dr. Asyraf Zaidi, stroke neurologist, Faculty of Medicine, University of Kabansan, Malaysia, Hospital Counselor, Tonqua, Muhriz, Kuala Lumpur, Malaysia. Dr. Asyraf graduated from University Kabansan, Malaysia for both his undergraduate and postgraduate training in internal medicine. He then completed his neurology training before pursuing advanced subspecialty training in stroke medicine at Royal Melbourne Hospital Comprehensive Stroke Centre, Melbourne, Australia. He is currently a clinical lecturer at Faculty of Medicine, University Kabansan, Malaysia, and a stroke neurologist and physician at the Department of Medicine, Hospital Counselor, Tonqua, Muhriz. Dr. Asyraf currently serves as Vice Chairman of Malaysia Stroke Council, member of the World Stroke Organization, alumni of WSO Future Stroke Leader Program, co-chair of the Malaysia Stroke Reperfusion Educational Program, council member of Asia Pacific Stroke Organization. He is also national lead investigator for Malaysia in several international multi-center randomized control trial, include Trident, Avertidose, Optimist, Main, the Brexia stroke trial. His research interests focus on acute stroke reperfusion therapies, stroke rehabilitation, and stroke prevention, particularly in patients with intracranial atherosclerotic disease. Dr. Asyraf, the floor is yours.
Assalamu alaikum. Thank you, Dr. Ali, for the kind introduction. I'll share my slide. So then put this one. And I put my slide to presentation mode. Can you see my slide now?
Is it clear? Okay.
Everyone can see my slide? Yeah, okay.
Yes.
So, yeah, please stop me at any moment if you cannot see my slides or cannot listen to me. So, thank you, everyone, for inviting, especially Dr. Mustafa, for approaching me to share something that I actually was trained, almost 8 years now, by Professor Bruce Campbell and Steve Davis in Royal Melbourne Hospital, and lots of other mentors over there, Bernard Yan and the group. Okay, so before I go with the stroke cases discussion, I'll just go with a bit of introduction. So there's no disclosure for this presentation. I need to just share a bit. In Malaysia, I'm from a comprehensive stroke center. However, we have limited access to mechanical thrombectomy because of the cost and also the limitation of interventionalists, and also the usual resources related to it, ICU beds, etc. So maybe we can have a discussion, and you will see how I approach the cases. Yeah. Okay, so stroke, as mentioned by Dr. Dylan just now, I'll just share a bit how a stroke neurologist perspective when I train my fellow. So it's always a clinical syndrome, and we need to know that this is due to the vascular disruption. As mentioned just now, whether it's a blockage, whether it's ICH, or which is bleeding, subarachnoid hemorrhage, rupture of the vessels. So it should be one or the experts in stroke should be trained to determine the diagnosis of stroke by clinical diagnosis. And reperfusion therapy is indicated for stroke patient who presented within your protocol. This is specifically mentioned the third bullet is because of not every single hospital will have the same expertise and the same approach, because of you need someone to be trained before you're able to interpret all the advanced imaging. So you need to decide what is your protocol. So the concept of stroke, when we try to approach the ischemic stroke, we need to understand about the penumbra, where this is the ischemic area, which contributes to clinical syndrome. If there's no clinical syndrome, that's benign oligemia. So if you manage to reperfuse it in whichever strategy that I'll share later, it may result in symptom resolution. However, if the patient is too late or we are a bit too late, then there's infarcted tissue. This is the dead tissue, which contribute to the clinical syndrome. However, if you attempt and you try a delay reperfusion, try to avoid this, because of then the complication may occur, whether it is a reperfusion edema or hemorrhage transformation, especially the PH1 and PH2. So stroke reperfusion, as we're talking in 2026, we know that since about 31 years ago, so lytics has already been approved. And for the past 2 years, lytics now, we have a new agent, tenecteplase, and few other new agents coming in. Mechanical thrombectomy in 2015 is being approved after Mr. Clean trial, and is able to extend in 2018, 2019 after the Dawn and the Diffuse trial. And recently, our Chinese group already then presented in the ESO and also World Stroke Congress. There's adjunct therapy, especially in the atherosclerotic disease patient, tirofiban, for example. And don't forget the usual approach. I always tell my fellows, we need to know the etiology of the stroke. Sometimes the reperfusion therapy is just manipulation of hemodynamics, which I mentioned over here. It can be the IVI, antihypertension, usually in acute stroke, or even hydration. And sometimes this patient had anemia, whether it's acute or chronic, which is symptomatic that you need to transfuse. So just to share the usual thinking process in majority part of, even in Malaysia, intravenous thrombolysis only needing CT brain plane, that's 1995. CT angiogram, because of the stroke is actually a vascular disease of the brain. So you need to know the blood supply to the brain. So it's quite standard to have a CT angiography from arch of aorta to the vertex or circle of Willis. And you need to determine whether there is an occlusion. Correlates with your clinical assessment. So we learned from the IMS3 trial, where they didn't do the CTA at baseline, so they didn't know the occlusion at baseline. There's some delay. And Mr. Clean improvised it. And from a negative trial, become a positive mechanical thrombectomy trial. So therefore, you shouldn't, delay the mapping of the occlusion, whether there is occlusion at baseline or not. And do not wait for reassessment after lytics for mechanical thrombectomy discussion. However, we know that sometimes there's a called remarkable early neurological recovery. Therefore, mechanical thrombectomy may be then terminated. So in limited access hospital, severe stroke, I would then advise, if they only can entertain the severe stroke, which they suspect by a clinical, for example, an IHS more than 10, with certain clinical scale, for example, LAMS and also fast ED. And you also need to look at the dense vessel sign that I will show in the non-contrasted CT. And also, you may plan for transfer for thrombectomy if you have the evidence of occlusion with or without advanced imaging. The problem with just using CT plane and you don't have the capacity to look at the CTA, is obviously the cost of transfer. So basically you transfer a patient with MEVO and DVO, but your system are not ready for it. And you need to repeat the imaging over there and there's no occlusion. So it's a waste of resources. Okay, so I'll share Raul Noguera, one of my mentor in journey as a stroke neurologist. We need to be fast. However, precision is still something that very much required because of, for example, in the in the middle income country, this is very much important. It's all about cost. So speed without precision is just a noise. So we should be fast, we should be safe, and we should know where we go. So if you look over here, the recommended stroke protocol, obviously, you should have a pre-notification. And from there, you can plan for direct to CT. Obviously, in Australia, for example, even in my center, what we do is basically to make sure the ABC is secure. And if the airway breathing circulation is secure, then the patient can go direct to CT with the stretcher. And we do in our centers CT plane, CTP, then CTA upfront, meaning at the baseline when they arrive. And I'll discuss afterwards how I approach, is basically to know the disability which involve. And we know that as simple as disabled should be the way to go. And for the non-contrasted CT, if you're confident with it, when there's no ICH and there's no definite stroke, there's no established infarct, especially when there is occlusion with hyperdense artery signs, which is in the majority, 80% of the stroke, then if you're confident enough, the diagnosis is clear, start thrombolysis here, even though the protocol requires CT perfusion at baseline. The CT perfusion is only required if you're not sure and you want to extend thrombolysis, for example, or even extend endovascular thrombectomy. And if you already have the idea of large vessel occlusion, at any moment, you should activate the discussion with your endovascular team for immediate mechanical thrombectomy, TAM, and assessment. So this is the approach where we need to be precise. If possible, by training, then you will be able, even at baseline from the stroke from the history and examination, to determine the possible etiology. And your approach will also determine precise prognosis and precise treatment. As you can see over here, so the aim of the imaging should be fast, accurate diagnosis, maximize eligibility of intravenous thrombolysis. A center that don't have experience how to use intravenous thrombolysis may not be good at all with endovascular thrombectomy. And try to minimize futile transfer because of this is all cost and also affecting the family. And obviously you need to always look at the key quality indicators to streamline the path to reperfusion. It should be fast, precise, and also safe. So some technical things that we do before we go for the stroke cases. So when you have a brain imaging, you should have the brain CT window, the window width of 80 or 90, the window length just at 40. And stroke CT window is the one with anything that dark become more darker, anything that bright become more brighter. So the windowing will be 40-40. And the maximum review of the CT plane should be 5 millimeter thickness. Preferably the one I will show to you later is 1 millimeter thickness. So if you use aspects, and if you know I'm from Royal Melbourne, being trained over there, we use it just for clinical trials. We have CT perfusion majority of the time. And the other things that you look just now, so first you will assess parenchyma. There's no ICH, SAH, and there's no definite stroke. You need to be able to determine whether the darkness is already infarcted, whether the darkness is early ischemic changes, as you may then read about aspects. You want to look at the pipe, which is the vessels for dense vessel sign, before you have the CTA or the CT perfusion to determine the vessel occlusion, correlating with your clinical assessment. Then you will master the perfusion imaging. So this is an exposure for a few cases that we're going to start. So this is how I approach. Number one is always you need to know the clinical history. in majority of time, you will get the clinical history. Although sometimes you cannot get the clinical history because of the NIHS is too high or the GCS is too poor. So clinically suspected stroke, okay, and CT perfusion, obviously very good. It was approved initially for stroke mimic. And identify stroke chameleon, if you almost miss one, faster and confidently is the advantage. The mnemonic here is high bosses. So I don't ask my fellow to call me high bosses all the time. The history must be a stroke. The blood pressure, preferably with all the clinical trials now for lytics and also mechanical thrombectomy, you can bring down to less than 180, 105 ICH, then you bring down to less than 140, 90. The onset can be up to 24 hours. I'll concentrate on this. We may do something beyond this, but for today, we know that recently, for the past 2 years, HOPE trial in China and also TRACE-3 trials, especially if you have ICATs quite a lot in your area, then yeah, this is going to benefit you. Sugar, obviously, you don't want to treat a stroke patient having DKA and also HHS with lytics or reperfusion therapy without telling them the risk is higher. Severity, as simple as disabling, so I don't have a lower limits and upper limits when I approach a case. And the scan must be interpreted, as I shared just now, fast enough with that sequence. So that's the tips to make sure that less than 5 minutes everything is already been done when you have the scan up for each moment from the plain scan, CT perfusion and CTA. Okay, so then CT perfusion interpretation will be quite fast. I would say less than 2 minutes in majority of the time. Any problem? Can I continue?
Okay, there is no
Okay.
continue. There is no problem.
Yeah. Okay, so to determine the ischemic area, the CT plane should be normal in majority of the time. So this is the art of darkness just now. So literally you need to know how to determine whether it's dark enough to be a established hypodensity, especially in the early window for the ultra fast progressor and fast progressor. The time to peak and also Tmax or delay time, they're almost the same, but I'll explain a bit more after this. And usually you look at this side first. In our imaging later will be on the right side. From your screen, it should be prolonged. The time to peak, which not concurring with delay time. For example, if you use Canon, the one I use today, I don't use the third-party software like Rapid or MyStar or Olia. So it may be stenosis and or recognition when it's not concurring. Time to peak or Tmax or delay time prolonged with the hypodensity just now, it can still persist when there's no recognition for infarction. The CBV should be normal in penumbra. CBF is reduced. And always check on the CTA again because of, that the CT plane was done first, CT perfusion and CTA. So it can just recanalize in front of you. If you do enough stroke call, that can happen. Obviously, for infarction, the CBV may be low, reduced. If significantly reduced, it's very difficult for you to beat the CBV majority of the time. But if you're fast enough, then you may beat the CBV, CBF assessment, then you call it as ghost infarct. By all means, if you manage to prove as a ghost infarct, but it's a stroke case. So yeah, you should just continue, treat the patient accordingly. Don't use it to perfusion to decline the patient. I'm not going to introduce that at all. And check the CTA. Always check on the CTA at the end. Okay, so we go to the case one. So with the case one, I try to show to you how then I for the first moment, how we go very fast first. Then we go with the other cases a bit slower to interrogate the imaging. So case one, 78 years old lady, underlying hypertension, follow up in the community clinic nearby. So she presented with right eye blurring of vision. So most probably this is a homonymous hemianopia at 11 a.m. Reduced consciousness, so there's a cortical sign at about 2 p.m. But however, there's no limb weakness, there's no fitting. The blood pressure is very high, so I told you just now should bring down 192, 115. So what we do is we bring down the blood pressure immediately to less than 180, 105. The pulse rate is 119. Initially was a sinus rhythm. then later on during admission, there's AF. So if I tell you that, then you already know what is the possibility. If AF unravels, a bit easier. Gastrostic is 6.5, so this is normoglycemic. Afebrile, oxygen is good. And when arrive, already start to respond a bit. NIHS is 6. So then there's right homonymous hemianopia. The scan was done at 7 hours from the index of blurring of vision. Okay, so we go to the imaging. So the first case. Okay, so this CT plane. So my team will then push me the CT plane immediately. Usually we start from the base of skull, go up to the vertex. The scan was done 7 hours after the first blurring of vision just now. So if you remember, I told you when the early ischemic area, then first thing is basically look at the scan for ICH first and whether there is definite hypodensity. So when there's right homonymous hemianopia, so then you look at the occipital area. So if your eye is sharp enough, then look at the value that I'll show to you later. Okay. So it's a bit difficult, but because of, obviously this is my case. So then if you look at the value VAL over there, 55, that's the dense vessel sign over there. Obviously easy when CT perfusion come up like this. So the CT perfusion, this is the TTP, the time to peak, when my cursor is moving over here. And this is the delay time. You see the time to peak and the delay time conquering each other. In majority of the time, there is going to be a thrombus. It can be a back-to-back called occlusion stenosis. However, with the thrombus and you have definite clinical symptoms, stenosis, you may have fluctuating symptoms or may have no symptoms at all. And this is the CBV, the one that my cursor is moving now, the first row in the middle. As you can see, I'll scroll up again, up and down again. Okay. The CBV is not too low. Okay, it's almost equal to the right side. Okay. If you look at the CBF is slightly low, but not too bad in this case. Okay. So if during 2025, no, not really 2025, like for the past 5 years, what I do is with a good CT plane, and there's a thrombus, we need to prove the CTA, remember? So the CT perfusion just tell you, I don't really spend time too much on interrogating on the CBV, CBF. And obviously, I told you I don't use rapid in my center. So we confirm now with the CTA. I'll bring up the CTA first. Can you see the CTA? So this is the arch of aorta. So I'm not going to teach you the anatomy this time around because I think you have the session before. I'll just prove to you. So this is where the CTA should be done. So from the arch of aorta, you can go lower if you want to look for left atrial appendage or the cardiac now with the recent trials positive. Recently to look for left atrial appendage clot. You go up and you follow through the vertebral artery now, become basilar. Obviously with the vessels which is occluded just now in the posterior. So you want to look at the PCA. So this is a PCA. So the PCA is a P1 segment where the PCOM is connecting. So that's the end of P1. Then there's P2 anterior and the P2 posterior. So just go through. So mid half of the midbrain. And then you see there's a stump at the area that I told you the dense vessel sign just now. For the beginner, so most of the time you like to use the MIP image. So you can plan call, for example, from this one, I'll just try to show to you. Oh, sorry, it's going down. So yeah, it confirmed there is a occlusion at the P2 segment posterior. So this is called early occlusion with not much of CT changes. So we then thrombolize the patient. So this is the CT pose. Let's bring immediately because of time. So you don't see much of any changes after the early reperfusion with alteplase in this case. I'll just stop there. If you really sharp enough, you'll see there's some changes at the occipital area over here. But this is very much minimal. So this patient had full recovery of her vision. Okay. So by right, from the CT plane, then we get CT perfusion. We don't wait much on the CTA interrogation. We know that CT perfusion with that called imaging just now, there's occlusion because we already examined the patient. So this is where called another statement to my fellows usually. The initial scanner is the neurologist that examining the patient. So you already scan the patient, you confirm with CT perfusion, and the patient is still symptomatic. It is a stroke, and you know that this patient is called able to be treated with reperfusion therapy, whichever strategy, the one that you're being trained. So we continue with case number 2, 76-year-old gentleman with hypertension, dyslipidemia, diabetes mellitus type 2, and also ischemic heart disease. And again, in this case, you can spell, just now I told the first case AF, ischemic heart disease is for this patient. Patient then had a sudden onset right-sided body weakness at about 7:30 p.m. and attended about 2.5 hours late, 2 hours later in our hospital. Initially, GCS was full and GCS became less responsive in ED. BP at home was high. Obviously, when there's occlusion, the blood pressure tried to respond, and on arrival, the BP is a bit better. Okay, and activated on arrival to the emergency department. And the dextrostic is reasonable at 9, so not too hypoglycemic. Bit of low-grade temperature over here. NIHS is high at 29. So when the NIHS is high, immediate drop in GCS, you know that it's possible ICH or large vessel occlusion. Scan done at 2.5 hours. Okay, let's look at the scan. Okay. So this is the CT plane. So similar like just now. So we're going through the CT plane from base of skull. Unresponsive right-sided body weakness. NIHS more than 20. 2.5 hours. If you stay far a bit from your chair, and obviously now you know that the clinical symptoms is mostly probably MCA, and this is a PCA before, history of IHD, so you smell this is cardioembolic. The first thing is all about looking at bleeding, again ICH or subarachnoid hemorrhage. Is there any definite stroke? So for sensitive eye and for trained eye, majority of the time you can see already a potential MCA stroke. In 1995, 2008, this is exclusion criteria. If you remember back then, we don't thrombolize a patient with this more than 1/3 MCA involvement, even with the EIC, at least in my called training before. So, but now we know in the last 2 years, the large core series already showing benefits. So as you can see over here, if I go slow, then you see the next one, which is the dense vessel sign over here. So this is at the proximal M2. But the NIHS high like that, you know that this is going to be a dominant M2 at least, or even this is still proximal M2. Okay, so this is for mechanical thrombectomy, even with the CT scan plane, you can already start the discussion. And this is 2.5 hours. I don't wait for CT perfusion in this case. The CT perfusion is just to confirm this is which we use majority of the time, the last one, actually the CTA first in this case. So you see again the time to peak, the delay time, conquer each other, MCA territory. And you see the CBV and CBF is quite low in this case, which then not shocking because of the CT plane is also showing early CT changes more than 1/3 MCA. And this is early CT changes. So I trombolize this patient. Sorry. Okay, I continue. So with this
Okay, no
called
problem.
okay, so I trombolize this patient as the CT plane called appear, and the CT perfusion to be truthful, we never see this one because we already know CT perfusion will be like this. And I bring the size from our vendor calculation later. But obviously, just to show to you, the same thing from arch to vertex to cut short because of time. Then you see the occlusion over there because of, I don't know the seniority of the people here today. So I'll just do the mapping again. So bring up, so you can see in this case, the proximal M2 is occluded over there. Again, CT perfusion, if you are a beginner, so then you should not miss the M2. There's another MCA branch too, which is missing over here, supplying the anterior segment. So this called dominant anterior segment. Okay. So this patient had immediate lytics and immediately activated the thrombectomy. So within 4.5 hours, thrombectomy finished and completed. So this is the post scan. Again, less than 5 minutes, all the imaging was interpreted once available. Okay. My sentence is not as fast as Melbourne. Melbourne about 2 minutes, less than 5 minutes, everything is available. CT perfusion may appear about less than 10 minutes. So yeah, if maybe 10 minutes or 12 minutes, we finish all the interpretation. But again, the CT plane give a clue for us to discuss. So despite these changes post thrombectomy, so this is a patient 7 days later. 6 days, sorry, 6 days later. You see the patient with a good physiotherapy and my stroke nurse and my physiotherapist able to mobilize. And at 6 months, he able to attend wedding, physically ADL independent, obviously left MCA. There's a bit of expressive dysphasia, but he still be able to communicate with his wife. Okay. Okay, ready for case number 3. This is a bit more complex. Just to challenge everyone. So this is 67 years old male, hypertension, bronchial asthma, ADL independent, presented at 4:40. So basically, with actually at 2 p.m. and immediately at 3 p.m. wake up with the right upper limb weakness. So this is a right-sided called weakness with facial asymmetry. Sorry, this one is, yeah. Okay, so let's see the scan after this. Maybe right and left is mixed up. But again, hypertensive a bit. But NIHS was 4 or 42 and GCS is full. So yeah, so let's see the scan. Sorry, this one is not this one. Okay. So this CT plane, we have time hopefully. So can you see any ICH? There's no ICH, no sudden hemorrhage on the first scan. However, I'll just stop here. But this is left-sided body weakness, yeah? Left-sided body weakness. And chest is full. So you see the dent vessel sign over here. Okay? So again, this is from the distal M1 to proximal M2. So this large vessel occlusion. However, the NIHS is only 4. GCS is full. The patient is not confused at all. If you're panicky with your CT perfusion, maybe you become more inclusive with mechanical thrombectomy. I didn't say it's wrong, but we know that we'll look at the CTA later. Okay, so what is the challenges to go with this patient? So this is basically a patient with, again, MCA, from the time to peak, delay time, again, conquer each other. And you can see the CBV, not much of low CBV. So you don't need to memorize low, because of you always have this indicator over here. Low means dark blue. And for the CBF also dark blue. Delay in the TTP is prolonged red over here, and also delay time over here. So you notice that I don't use much of the MTT, because of sometimes MTT also full of noise, and the new Bayesian model, I think, is not really useful. You just need the time to peak, or Tmax, and with the delay time. You can see the CBF is low over here. Okay, so it's confirmed as MCA occlusion. Is it just MCA? Let's see the CTA. Okay. So yeah, I forgotten to tell about the windowing for the CTA. So usually we use window length of 250 and the window width of 750, but depending on your screen resolution. So you can see this is a bit different when I use my screen now. So we go down to the arch of aorta. We go up immediately. So look at the carotid on the right side, because of that supplying the MCA. And you can see there's atheroma over there with calcification. Follow through this atheroma on the right side. Complete occlusion of the right carotid. So maybe there's a thrombus over there, or this is a chronic occlusion, NHS4, remember? But you see a bit hint of the intracranial ICA over there. It can be a trickle flow from intracranial. That's a bit unlikely here because of its absent. Then you see the MCA going down a bit. MCA is occluded because of the thrombus that you see from the dense vessel sign. Okay, NHS is 4. Early arrival, but less than 2 hours. So this patient, what we did is basically we lyse immediately. So it's controversial because of his, by diagnosis now is, in certain center we call it controversial because of his tandem. You might need to deploy a stent if you choose to do endovascular thrombectomy. So in this case, we choose to go for medical therapy because of the patient had issues with the payment for mechanical thrombectomy. So we thrombolize this patient, and we then approach it at large artery disease. We give immediate tirofiban. So we hydrate this patient, immediate tirofiban. So this one, I need to show you the post scan. Another tips about the scan, always look at the full scan. Okay, so this is a post-lytic scan. So NHS4 increased slightly to 6, some cortical sign, but about less than 24 hours later, the GCS improved, NHS become 2. Okay, this is the 24 hours. You see there's some dense vessel sign a bit, but not still almost like if you look at here, like the whole dense vessel sign is still there. But again, it's very much clinical. You need to then see the patient improve in front of you because of the proximal M1 is actually distal 2/3 of the proximal, the M1 is occluded. You see the vesica ganglia is infarcted. But if you follow through, there's a bit of calcification over there. And the subarachnoid hemorrhage over here. It can be reperfusion hemorrhage, or it can be also a convexal hemorrhage because of severe stenosis. So because of the improvement of the NIHS and stabilization of the hemodynamic, we didn't go for endovascular in this case. And this is CTA post-treatment. So remember the proximal carotid was occluded. Okay. But now it reopened. I continued tirofiban almost 20, slightly more than 24 hours, then changed ticagrelor. Because of there is a moderate stroke over there just now, so we didn't go for early CEA, and obviously we stand by for carotid stenting at any moment. But as you can see, regionalization of the proximal MCA. So this is a few days later after the previous CT plane. But yeah, still you call this is early CTA, you don't see much of the perfusion over here. But again, by clinical, this patient GCS improved, weakness improved, and we able to mobilize him. Hemodynamic didn't respond at all to any possible occlusion over here. Hemodynamic correspond usually sometimes it can be labile going downward hypotension. Mostly they become hypertensive and then symptomatic. So you mobilize the patient. Ischemic stroke for mild moderate severity, we can mobilize within 48 hours. Okay, so that's a post scan, and 6 weeks later, between that time, 5 weeks later, we went for CEA. So the culprit just now, the arteroma being removed, and the patient now already about 6 month MRS 0. Okay, so the last case sharing today, 54 years old gentleman, background history of smoker, hyperlipidemia, ADL independent, very active. I'll show to you why I mean very active, which I never know. I was watching movies during that time with my children. The upper limb weakness is on the left, which is still 4++, and mild slurring. He can still talk, but there is evidence of slurring of speech. Blood pressure slightly high. Again, when there's occlusion, heart rate 60, oxygen okay, dextrostic is okay, or glucose okay. GCS is still full. Left-sided upper limb weakness. So basically, you know, this is no lower limb weakness. So it's MCA trend. NIHS is 2. So is it just non-disabling? Scan done because of this definite stroke at 17 hours. Okay. So this is beyond 9 hours. Oops, sorry. So we go with the last case. You can see immediately the transverse sign over there. So I bring down. From base of skull, again, there's no ICH and there's no definite stroke despite the patient at 17 hours from the index symptom. Because patient DCS full, so he can share with you. But do you then just want to antiplatelet this patient? During that time, this is 2023, the tirofiban trial was not published, and I don't know about tirofiban at all. So, yeah. But this is a very, again, you look at the parenchyma, very nice scan. No definite stroke, despite 17 hours. Okay, dense vessel sign. I'll just put my cursor over there. So this is a fresh clot, 68, more than 50 ounce fill unit, proximal MCA. So just by anatomy, you know this proximal MCA. CT perfusion make life easier. Okay, I'll just make it smaller. So below. The CT perfusion also can diagnose multiple territorial stroke. Sometimes you miss it. Okay, but this one is just one territory, MCA. Again, it conquer each other. But one will say that basically this is a bit of hyperperfusion. But again, that's the reason why you need to examine the patient and you see the clot over there. You need to check the CTA, whether there's concurring stump correlating with the clot over there. Okay. So this is the first CTA. I'll change a bit the windowing, so make sure that you all can see the lumen. CTA good to see the lumen, so that's why we use in hyperacute. So you see this is the normal side. You can see the continuity of the MCA. However, this side is still ICA, almost proximal MCA in this case. Sorry, distal ICA, proximal MCA. Okay, to go down, sorry. So this is ICA. Yeah. Okay, so concurring with the dense vessel sign just now, cannot see any enhancement of the distal MCA. Okay, this is the CTA. So in this case, what I do is basically I'll ask the patient off-label. We know that the recent studies, which is PRISM, terminated early because of funding issue, and being analyzed and says that there's no benefit of lytics versus standard medical therapy. And the recent study Tempo 2 for mild NHS SN5, that's a bit risky. However, I think that the study was done in a different setting. So we in Asia, I'm not too sure in Iraq, but in Malaysia, we have lots of ICATs. So there's a study published in the AJNR and in 2019. So I concur with it. And 80% of the time when there's a thrombus, if you then just treat this medical therapy, and furthermore, our patient may be then also Plavix resistant, cannot afford ticagrelor, for example, then the patient might deteriorate. And in this case, we want to go through potentially this is a severe ICATS. It may cause a nightmare for the patient, whether dissection or forations. Okay, so I'll show to you the post scan to realize this patient off label. Actually, after completion of the lytics, the symptom resolve. You can see the dense vessel sign resolve. Some changes in the MCA subcortical territory, which then explain why the patient total resolution, there's no other cortical sign. And then if you go with the CTA here, the CTA here, just bring because of time. So you see the proximal MCA, which is not there before. It's very small and very severe stenosis of the MCA. So then for interventional, even in my center, then you should just go in and you can plasty that proximal MCA. Total resolution, lower NIH chest, we have seen where there can be a dissection because of you try to plasty, you cause micro dissection, there will be SAH, more symptoms, prolonged admission. This patient just require 5 days admission, optimization of the medical therapy. And this patient already almost 2 years plus post stroke. And this is the patient. He's still able to act. So he's an actor. With his permission, he's still ADL independent. And recently he able to complete 21-kilometer half marathon. So, but yeah, the thing here is, if you notice the first 2 cases is cardioembolic case, immediately with clinical supported by advanced imaging, almost immediately, less than 24 hours, you know what the etiology. And the last 2 cases, large artery disease, which involve the extracranial carotid, also intracranial. And this one is a large artery disease intracranial or ICATS. And the patient's compliance to the medical treatment, with good treatment to prevent the next stroke, the patient then continue without any required intervention. Okay. Okay, so that's it. That's my last slide here. Thank you.
Thank you, Dr. Ashraf, about this more informative lecture. Dr. Dilan, please, do you have any comments?
Thanks, Juan, for... Can you guys hear me?
Yes, I can listen to you, yes.
Thanks, Juan, for the nice presentation. I think we both went to the same hospital. I was trained partly by Professor Peter Mitchell back in Royal Melbourne Hospital. That was like more than 10 years ago. And I was a consultant at the Austin Hospital, as well as Royal Prince Alfred in Sydney. It was great to meet you, at least virtually here, and hopefully we'll meet in person one day. I just want to add one comment. The common observation that we had about the lowness score patients, the 2 patients that you had, one was 4 by memory and the other one was 2. The common pattern they had one had an ICAD, and the other one had a tandem lesion. And this is just for the guys listening. That means there's some chronic nature of the occlusion that's helping in forming a better leptomeningeal collaterals and being the reason of not having a massive stroke score to start with. And this is an area of debate. And what you've done is great, because forming leptomeningeal collateral help these patients and along these lines. And so this is the thing to remember when you have a patient with shocking imaging finding and not that much of a clinical translation. That means we need to think about that there's some chronic nature of the stenosis or the occlusion, be it an ICAT or extracranial ICA stenosis, tandem lesion, or both. Other than that, I prefer the same thing. We used to have rapid in Australia. I don't have rapid now. I rely on just what you call it, CTV and time to peak and all this, as you mentioned. And that's how I was trained as well, both in Melbourne and Sydney back then. The other thing I want to add, do you, just one quick question, do you rely on MRI in any way for your patient selection?
For the reperfusion therapy, Dr. Dylan, is it? So if in the reperfusion, I would say, yeah, almost 99% nowadays we don't use MRI for reperfusion selection because of our CT perfusion is a whole brain CT perfusion, as you can see just now. Yeah, we don't use MRI, but we start to use MRI at 24, 48 hours. For the significant disability, then we do at 24 hours. But for the mild stroke, we wait up to 48 hours to determine the lesion. That is mostly for prognostication of recovery and also diagnosis sometimes. Yeah.
Very good. And do you always use CT perfusion even if the presentation is below 6 hours?
Yeah, so basically, we use like Royal Melbourne Hospital. So similar like the recent taste trial. So we when I came back in 2018, yeah, we changed that for all patients, 24/7.
24/7. Okay, thank you very much. Thanks for the presentation, and I'll give it back to you, Ali.
Thank you, Dr. Dilan. Now we will move to the question and answer session. Will be arranged by my colleague, Dr. Zahra Hamid.
Thank you, Dr. Ashraf, for this nice lecture. Now we will move to questions by audience. The first question from Dr. Hawra Mahdi about case 2. She's asking, with the NIHS of 29 and very early presentation under 2.5 hours, how much should we rely on perfusion parameter like Tmax or TTP to decide the immediate intervention, regardless of what the initial CT shows?
So yeah, as I mentioned just now, thank you, Tazara, for sharing that question. So for the early presentation, basically again the CT plane is called the most valuable one. So even though you see there is more than one third MCA involvement, called the CT perfusion is just to share with you where the CBV is quite huge. Predicted core. Always remember perfusion is about prediction of core, not a core yet at 2.5 hours. Majority of the time is not going to be a core. When it's less than 3 hours, 4.5 hours. So the CT perfusion is just to just tell you, look, this is the usual thing. This is a cardioembolic case, large core. You need to be very fast. Tell your interventional team you need to open the lab as soon as possible. Don't try to delay recanalization beyond 6 hours or even the Hermes 7.3 hours. So the faster, the better. As I showed to you, the patient less than 4.5 hours recanalized. Within 1 week, the patient able to mobilize. CT perfusion is very much of low value for the second case. It's just academic.
Okay, the next question from Dr. Mustafa. He asked about the limitation of using CTP.
The limitation of CTP. Is it correct, Zara? So basically, yeah. So I would say limitation of CTP, if you are not trained to use it, you might be confused and delay called interpretation. And I would say just keep it. At this moment in 2026, it's all about CT plane, CTA, accurate CTA, but with CT profusion on board, you then may not miss the MEVO or the DVO. So, or, the stroke chameleon. So like yesterday, I'll just thrombolize called superior cerebellar artery, which are often being missed and put as a peripheral vertigo. So, so basically, I would say the only thing, if you don't know how to use it, that's one thing about CT perfusion. And obviously, it's about technicality of your system. If the radiographer don't know how to do CT perfusion, the computation because of the technicality of the computer, the transfer of image, so don't use it if it delays call interpretation. So that's my advice. So as I mentioned to you, in Melbourne, we less than 2 minutes we get everything. As I remember, 5 minutes we interpret everything, but my side is about 10 minutes we finish everything. Uh, so I think it's not a big issue. But if you need to do in certain hospital in Malaysia, it take about 30 minutes, 1 hour. Never use CT perfusion for that called condition. More than 30 minutes, I think it's not acceptable.
Okay, the next question from Dr. Jardis. He is asking about any experience with low aspect score for thrombectomy.
Oh yeah, as I showed just now, it's basically the second case. If you do the aspect score, I think it was reported as aspects 2 in this case, and I didn't show you the volume. The volume is about 95 mils, 92 mils. So it's a pretty large core at 2.5 hours. So yeah, by definition, it's a large core case. We do that. However, the issue about large core is basically you need to be very, very fast. Again and again, when I show this case to other hospital in Malaysia, the system must be prepared because of if you post a case, the case must be done immediately, like in the called the well-developed system, and immediately being sent to a proper care, like in my site just now, is stroke care unit or intensive care, then early rehabilitation. The problem with large core is resource called exhaustion because of if they require usually prolonged admission, they require detailed or called intensive assessment throughout. So you need to know how to take care of the patient. This require a bit of more technical discussion about the large core. We only discuss about large core. It's a positive trial, but you don't know how to take care of the patient. It's not similar. That's what I can share with you in short. Yeah.
Okay. Dr. Tamim Nasser asking, can you depend on partial brain CT perfusion scan to select patient for extended window thrombectomy?
Sorry, that's a very interesting question. So I would say if at all you go with a stroke history, you think there's an occlusion via history and examination, you get any information whether CTA or whether you get perfusion with CTA or multi-phase CTA now, there is a called software doing that. I would say look at the thrombus and you need to know that usually the one that I showed to you, the fresh thrombus will then able to recanalize. Look for dense vessel sign. The other non-dense vessel sign or very calcified thrombus, obviously, I'm sure Dr. Dylan may also then share, is the lytics of limited value. So this will require a bit more understanding. The answer is definitely yes, but in large, having CT perfusion makes things faster with less hesitancy. So confident and less hesitancy. So, but with plain CTA, you can do that. I always tell my fellow, I don't need CT perfusion sometimes because of you get CT perfusion vision. The one that being trained with CT perfusion, I think those that are already exposed to CT perfusion, you see the image, you can imagine the perfusion deficit. Seriously, yeah.
Yes. I think that there is no more questions. Thank you, Dr. Wan. The word is yours, Dr.
Thank you,
Ali.
Zara.
Thank you very much, Dr. Ashraf, for this excellent and highly practical session. We would also to thank our panelist, Dr. Dilan, and all audience for their valuable contributions to the discussion. We kindly remind you to follow the Iraqi Stroke Network on social media and to join our network if you have not done so already. In addition, we are pleased to invite you to visit our newly launched official website, where you can find information about our educational activities, upcoming webinars, stroke initiatives, and way to collaborate with Iraqi Stroke Network. We encourage you to explore the website and share your feedback with us. Your feedback is always welcome and help us continuously improve our educational activities. Finally, we sincerely thank Abd Ibrahim for support this webinar. Thank you all for all participants. We look forward to welcoming you to our upcoming Iraqi Stroke Network webinars. Have a wonderful evening. Dr. Ashraf, thank you again.
Thank you, Dr. Ali. Thank you, everyone, for inviting me. Assalamu alaikum.
Thank you. Thank you.
Thank you, sir. Hope to see you soon.
Inshallah.
Inshallah.
Good night. Assalamu
Good
alaikum.
night. Alaikum salam.